Hey, so I have a super interesting case. I treat a lot of people with diabetes and a lot of type 2, but I do have a small percentage of my practice is type 1 patients. And I have a patient that went into DKA last fall and was diagnosed with type 1 based on the presence of two autoantibodies, in this case, GAD antibodies and then zinc transporter antibodies. And then a low C-peptide, which is the way to measure if our body is actually producing insulin. And then the patient did really well with small amounts of insulin and bulicine, very little amounts because they were doing a really good job with a low carb diet and exercise. But now the person doesn't need insulin, and really hasn't for the last little bit and is experiencing lows when they do have, insulin. So I, haven't had this happen in my practice before because a lot of my patients that I've managed on pumps have been, on pumps for a while, or they're coming to our practices, to help maintain things that have had type 1 for years. I've actually only had new onset a few times. One was in a 74-year-old woman with Hashimoto's. That was a new onset patient, but to my knowledge, she didn't go into remission. But this person may be considered in what we call a honeymoon phase, where they actually don't need insulin or need much less insulin during that time frame. But I was starting to go down to the literature because I was trying to figure out, is there anything that you can do to prolong that? And I was even thinking there's a new drug called Tzield, which is really expensive but can be a game changer in, pushing off, for people that are an early type 1, patient. That though is not necessarily approved in this patient that's already been diagnosed fully with type 1. Although I think that they might qualify if we had now's information, but this person's C-peptide is actually normal now. And so antibodies are probably still positive. They don't necessarily go away. But there's some interesting evidence about Sitagliptin, which Sitagliptin is a DPP-4 inhibitor. So DPP-4 is the enzyme that breaks down GLP-1. So it breaks down your endogenous GLP-1, which GLP-1 is that hormone that everybody's talking about. And it tells the brain you're full faster, and it slows down your gastric motility so that blood sugars don't spike as much. So in the presence, or in type 2, this drug is approved for type 2 diabetes, although it doesn't really work very well. It might have an A1C reduction of 0.8% at best. But the cool thing is that there's several case reports about this medication being used in this type 1 population that has actually gone into remission or in this honeymoon phase and prolonged that. And so there's even a case I found of someone that was type 1, and they were diagnosed at 33, also had Graves' disease and family history of other autoimmunity. And then after a period of time, 3 months of treatment, their A1C was controlled and they were in complete remission of the disease based on their lab numbers. And this person's C-peptide was actually even lower still, but they were not needing insulin, but it was still within normal range. So interestingly, the person was put on Sitagliptin, which is, again, this DPP-4 inhibitor, blocks that enzyme that causes GLP-1 to be broken down. And their C-peptide has gone up, and in the last follow-up, they've been in time in range. It was 88% of the time in this case report. And so it's based on this was in 2023 when this was published. It was the longest remission ever described in the literature. And the patient hadn't been on insulin since 3 months after diagnosis, and was taking the Sitagliptin 100 milligrams. But they were also doing a somewhat low carb diet, regular physical activity. And so it's super interesting that this DPP-4, again, it's a transmembrane glycoprotein involved in the metabolism, the incretin hormones, the GLP-1, and even GIP, but it also has some T cell immune response due to T cell activation. So there's this discussion that this can have immunomodulatory effects and regenerative proliferative effects in the beta cells. So I'm super intrigued. I'm going to be discussing this with my collaborating physician and our patient. But yeah, so if you've ever heard, this is why I get really fired up about off-label use of medications and the fact that some providers and pharmacists are out there trying to prevent this, and even that our drug the process of getting a drug approved on a PBM, like, has to be with a labeled indication these days. And it's like, if this is keeping this person from needing insulin for 6 years, like, I really hope that if this requires a prior authorization, that someone's going to approve it, right? Like, based on this case report, like, it is not that expensive to try. So I just feel like sometimes I get really frustrated with the prior authorization system in our country because, you know, I spend all this time writing up. I had a recent patient that I tried to get a GLP-1 for, and person has sleep apnea. They have prediabetes. This particular molecule I was trying to get approved was actually one that treats sleep apnea or has been officially approved for sleep apnea. Wrote this whole nice thing, put all the references. Nope, we don't cover this unless you have type 2 diabetes. It's like, why are we even doing the PA? Why are you paying someone to review this? If you are just going to say, we are only looking at this for patients with type 2 diabetes, end the process there. Don't waste my time on doing a PA. Anyways, that is a little side rant to this situation. But I would love to hear from other providers out there, like, what are your favorite off-label uses? I know a lot of us use low-dose naltrexone for things, for immunomodulatory effects. But if you have other favorite pearls, I would love to hear them. And I'm definitely going to be linking this in the stories along with this case report, because I've been in the diabetes space for a really long time and never heard of this. So I was excited to come across this.